Right. Good morning to the NAS Healthcare Simulation Success webinar. I'm Stephen Rotsky, and very nice to see so many of you on screen. There will be quite a few people joining us, but let me introduce you to Johnny Evans, the resource lead of NAS. Johnny, just a word or two about yourself.
Yeah, morning. Um, like Stephen said, my name's Johnny Evans. I'm the resource lead for NES. My background is critical care and resuscitation um, as an instructor and a provider and team leader. My role in NES is to support you as the doctors dealing with simulated emergency situations, but also there for advice for um, real emergency scenarios with your patients.
And Johnny, I certainly looked through a lot of the resuscitation scenario reports that we are receiving almost on a daily basis. So, Johnny, we look very much forward listening to you. There will be questions at the end. If you have got a question in the meantime, please use the chat function. And if we can ask you during the webinar just to stay on mute with your cameras off, so it doesn't distract from the slides. But very welcome to add any questions in the chat as and if Johnny is talking. If you have got a question, put it in there, and we're going to try and answer that at the end. Johnny, happy to listen to you.
Yeah, so like Stephen said, I see all the reports that come through from either from the external provider A2E or from in-house simulations that happen in the hospital. The reasons these happen is for their risk stratification and to reduce the risk to patients. So when I look at the reports, bear in mind that I can only see what's written down. My role is to support you going forward and add any learning to the reports that I see. So in terms of what we're going to go through today is we're going to identify the expectations of you as the team leader. These get identified in a lot of reports that I see. Discuss the scenarios that you're likely to be exposed to in your clinical settings, and then identify the treatment pathways according to the RCUK. We'll discuss the common themes that impact simulation outcomes, and this may be, one thing could make the difference between a low risk and a medium risk on a report. We'll review the algorithms in relation to adult and pediatric patients. And then my details are at the end. I am there for support, so please do phone me or email me, and I'll be able to try and help you as best I can. So, in terms of the expectations of yourself, then as a team leader, because in your hospitals, you are most definitely sometimes the only ALS or EPALS provider in that clinical setting. So, they expect you as a team leader, when you manage a team, you need to be introducing yourself as the team leader. Um, Request a handover from the first responder. So usually you won't be the first person to arrive at the patient or the simulated patient. So when you get there, you need to be requesting a handover. So remembering that 80% of diagnosis is from history as well. You need to allocate your roles to your team. Now, this may be that you've had a resource huddle, hopefully, in the morning, and every member of the team knows their role. But sometimes, over the course of the day, the staffing change may be that people that arrive as part of the emergency team do not know what role. So by allocating your roles to your team, this helps for anything being missed during your simulation. Now, in terms of your allocation of roles, though, what you need to be doing is only allocating roles to people who are competent to do that. So in terms of defibrillator, as long as they've had the training, adequate training to be able to use the defib, airway management, those skilled in airway management, in most of the clinical settings, what I see in the reports is they tend to come from the theatre setting. You need to carry out a structured A to E assessment of the patient. This is the most common thing that we see is unstructured A to E assessments. Remembering that your A to E assessment, you're treating what would kill the patient first. So in terms of that, in your manual, it's page 33 to 38. And even myself, when I go back into ITU, I still have a look at my little notebook just to refresh my memory, because if you don't use something, you lose it. So skill fade is quite common, especially in highly stressed situations. So it's good to just keep on top, and it's good for your own personal development as well. Good communication skills. This is quite a big thing in terms of communication. You need to be closing that loop of communication in terms of asking one of your team to carry out a task and asking them to tell you once that's done. That closes the loop, but it also lets everyone know that you're in charge and you're the team leader during that situation. They expect you to manage the cardiac arrest appropriately and escalate the treatment. So that is a given, being your role as the team leader. Now, the escalation of treatment may be that you have to escalate the treatment by transferring the patient out. Your clinical setting should have their own protocols for how this is done. If you have an ITU, it may be that you're transferring to ITU. If you do not, then it may be that you'll phone 999. So the scenario, any questions about that at all?
Johnny, there's no questions in the chat. So if you
Okay.
do have any questions, please add it to the chat function. And if we can ask you just to keep your videos off for us, that'll be very kind. Thank you.
So in terms of the reports, these are the reports in terms of what we've seen this year so far. So and how we deal with them. So ACS. So remembering, if you have a patient who's presenting with ACS type symptoms, then treatment wise, we're looking at aspirin, 300 milligrams chewed or crushed, GTN, but GTN only if the patient's systolic is not below 90, because we don't want to cause any more issues with the patient. In terms of oxygen, now this is quite a contentious thing in terms of the BTS guidelines as well, but if you have a patient who looks sick, then give oxygen until you can prove that they don't need it. However, if the patient is saturating at a normal amount, then oxygen should only be given less than 90% on their SATs, according to your manual and the guideline. In terms of morphine, so for morphine, giving morphine, this should be titrated to the patient response. In order to be able to titrate to the patient response, you need to carry out a pain score. Now, there are lots of different ways of pain scoring. Whatever pain score is used in your clinical setting, that should be done, and then you would titrate the opioid to their response. Remembering as well that we would probably give an antiemetic to that patient as well, just because of morphine can make patients sick. And if you've got a deteriorating patient, you don't want to cause yourself more problems in terms of airway. In terms of where they need to go, they would need to be transferred out to the NHS. It may be that your clinical setting has a NHS trust as part of it, or it may be that you are in the NHS. If that is the case, then the appropriate transfer should be done. If this is through the emergency services, we always have to remember how we're handing our patients over so that they can categorize them in terms of urgency. So I saw a couple of questions come up, I think, in the
There's no questions yet,
no?
Johnny.
Okay, cool. So if we move on to PE, we've seen a lot of reports with PE as the patient complaint. Now, in terms of how we deal with it, we do a structured A to E. This is on every patient that you'll see, structured A to E, and you may well treat with CTPA if that's available, if the patient is alive, low molecular weight heparin, or if the patient is in cardiac arrest. And this is stuff that I do see a lot of, is if they're in cardiac arrest, then it is thrombolysis or thrombectomy. Thrombolysis is more common to be used as a treatment, and that is usually alteplase, but your own clinical setting will have their own protocol for what you use for thrombolysis. If it is that you don't treat with thrombolysis in your clinical setting, then the patient again needs to be transferred out for that. In terms of when a patient goes into cardiac arrest, if you've already made an emergency call to 999, then you need to upgrade that category. So if they've gone into cardiac arrest, it's a case of rephoning the emergency services and letting them know that the patient is now in cardiac arrest, because ultimately, if you're in a hospital setting, that's classed as a place of safety. But by informing them that the patient is now in cardiac arrest, that will change the response time of the emergency services, because as we all know, they're very, very stretched at the moment. Stroke wise, on your A to E assessment, this is why A to E is so important. On your A to E assessment, on D, for disability, you want to know whether there's any new onset confusion. If there's new onset confusion, then that should trigger your mind to carry out a fast test on your patient. That, along with history, may indicate that the patient may be suffering a stroke. And in terms of that, then obviously they need transferring out or transfer into a higher level of care if that's available in your setting.
Johnny, if I just stop you there for a minute.
Yeah, of course.
There's a question about the GTN, the caution for the GTN.
Yeah. What is the question?
If you can
Sorry.
just repeat it, the caution for the G.
Yeah. So with GTN, how GTN works is it vasodilates, as we all know. So that reduces the effect of ischemia. However, if your patient has a systolic blood pressure of less than 90, then we wouldn't administer that, and that's in your manual as well.
And we also look at the right coronary here, isn't it? That's included for your posterior infarct. Remember, they will have the lower blood pressures, the low pulse rate. So be careful for the GTN. And then, Johnny, just a second question there. If thrombolysis is not available and no CTPA, and the patient is clinically more likely to have a DVT or pulmonary embolism, can low molecular weight heparin be given? And what is the treatment dose?
Yeah, so the treatment dose, the simplest answer to that is you would need to look it up, and that's the safe thing to do. In terms of we would only use that if the patient is alive. If the patient is in cardiac arrest, and that is when you would use your thrombolysis, i.e. your outer place. But if that's not available, you need to be transferring the patient out to an appropriate setting. So that would be an emergency department within the NHS, so by blue light.
So I
Hopefully
think
that
really
answers.
important there to if you're not sure about the dose, just look it up. You know, we've got all devices, the BNF, always with us. So always be careful with the dosages. And if you are in a scenario and it has been tested, the correct answer is always, can I just have a quick look or ask someone to look it up for me, especially with the dosages.
Yeah, because we're not walking BNFs. You know, there are certain things that you're expected to know. You're expected to know the emergency drugs, um, but in terms of treatment drugs, the safe practice is to look it up. Um, that yeah, that would be the simple answer.
Yeah, and on that note, don't be afraid to ask for the algorithm. Don't be asked to ask for the file. And on
Absolutely.
your resuscitation trolleys, you should have the algorithm. So don't be afraid to ask for that in the scenarios. Right, Johnny, anaphylaxis.
Yeah, so in terms of anaphylaxis, we've seen quite a few in the last 3 months of these used as scenarios. The important thing is asking for expert help. So you want anesthetic support because remember, anaphylaxis is classed as an A problem with or without a B problem, with or without a C problem. 30% of patients do not present with a rash as well. So, you know, on D, on E for exposure, then yes, you would be looking for a rash, but it does, if they don't have a rash, it doesn't mean that the patient is not having an anaphylactic reaction. Um, request the algorithm is don't be afraid to request algorithms because it is safe practice. Obviously, the dose in terms of adrenaline would be 500 mics. If you're drawing it up yourself, then it is half an ampule. This would be given anterolaterally in the thigh, and what you need to remember is it is 1 in 1,000. So it's a higher concentration because it's given IM. Once the dose has been given, then continue your A to E assessment. When you come back to reassess your patient, which we usually give it 5 minutes, then on reassessment, if there is no change clinically, then repeat the dose, but the same dose, but repeat it on the other thigh in terms of adrenaline works by constriction as well. So we don't want to be giving it into the same site that we previously gave it. Like I said, you're asking for anesthetic support very early. Now, what anesthetics or intensivists can do for you is to give you the patient an adrenaline infusion. So I've seen in quite a few of the reports that a adrenaline infusion for refractory anaphylaxis hasn't been requested. If you're stating that you want an anaesthetist because you want airway management, because obviously in anaphylaxis the airway's at risk, then also do state that you would, if there was no change in clinical response to the IM adrenaline, then you would consider refractory anaphylaxis, and the person to do that would be the anaesthetist, because you wouldn't do IV adrenaline unless you're skilled in that area. So moving on to massive hemorrhage, is there a question on that, is there?
Yeah, as for someone that said, I've seen hydrocortisone and IV peritone being given for anaphylactic reaction post chemo in oncology. Why is the approach different?
So in terms of anaphylaxis, then your emergency treatment is always adrenaline. Post chemo, maybe that is a specialist area. The trouble with hydrocortisone is it takes a long time to work. And if you have a patient with anaphylaxis, the emergency treatment is adrenaline.
Yeah, someone
Um,
once described hydrocortisone to me as the cover for the rebound if the allergy is coming back and the adrenaline have stopped working, then
yeah,
the hydrocortisone will work. But you need about an hour for that to kick in, sometimes longer. And the
absolutely.
peritone is just to help for the itching and the rashes maybe. But
Yeah,
there
well,
must be a clear distinction with the anaphylactic reaction that we're going to see that needs the emergency 1 in 1,000 adrenaline and the after medication, the hydrocortisone and peritone that we can give.
yeah. And the way to identify this is by carrying out a structured, thorough A to E assessment, because that will tell you the first thing to go clinically on a patient and will tell you how sick they are as their respiratory rate. These do get missed on reports quite a lot. Respiratory rate is the biggest indicator of a patient deteriorating in adult patients and in pediatric patients. But it's the one thing that's overlooked so often in hospital settings.
Yeah, then an interesting question, Johnny, was do we verbalize anesthetic support even if your hospital doesn't have an ITU setting? In hospitals where anesthetists are not always available,
Yeah,
are around for
that's
surgery or scheduled. What's
absolutely.
the get out of jail card there for the scenarios?
So you would, if you do not have anesthetic support in your setting, i.e., there should be anesthetic support if there's any surgery taking place in your clinical setting. But if you don't have it, then the get out of jail, as it you put it, would be to phone 999, because they will be able to, a critical care team will be able to manage the airway.
Yeah, and maybe on that note, please go and have a look at you or your hospital should have an on-call anaesthetist rota. Always good to have that or knowledge of where it is stored or the telephone numbers. Specifically, if you do surgery in your hospital, that should be available at all sites. Maybe good
Yeah,
to have that as the leader of the resource team at hand.
yeah, but I do appreciate that mental health sites may well not have that, and the go to then would be to phone 999 and obviously SBAR handover to the emergency services. If you're worried about someone's airway, that would be a category one call to the emergency services. Does that answer the question?
Yeah, if
Yes, this
anaphylaxis,
is
do we
map
give,
like scholarship kind of.
can we just ask, if anaphylaxis, do we give fluids? What if the blood pressure is showing normal on the monitor?
Yeah, so like I said, anaphylaxis is an A problem with or without a B problem, with or without a C problem. By treating it, by treating it um, in terms of with adrenaline, you would want to get access, and running through it, fluids through is not, is not a no-no, because the patient will obviously vasodilate anyway. So I would treat them with fluids, even if it is just to keep the cannula patent. Really, does that does
Yep,
that make
I
sense?
think that is definitely the right answer.
Um, so obviously remember oxygen straight away. Any sick patient gets oxygen until you can prove otherwise. So in terms of massive hemorrhage, we've seen a few of these reports come through, and the one point that does seem to get missed on it is the direct pressure to the wound. So direct pressure, limb elevation, if it is a limb, if that is possible with a patient, IV access and fluid. Obviously, if the patient is losing blood, the best replacement is going to be blood. If you carry out surgery at your sites, then there should be emergency blood available. If you're on a site that doesn't have that, then again, it is an emergency services call, stressing that the patient is having a massive hemorrhage. We would also treat with TXA, but I appreciate that that TXA isn't always available at all sites. But there is a school of thought at the moment about if the patient has an abdominal bleed, whether the use of TXA is not indicated. In terms of sepsis, now sepsis is, it is still a massive problem pre-hospitally and in hospital. I worked in both areas. The sepsis 6 is written on the side of ambulances, and it still gets missed pre-hospitally. And there are still patients that red flag sepsis, and it still gets missed on multiple occasions. So in terms of sepsis, oxygen, IV fluids. Now in your manual, it gives you a guide of how much fluid. Realistically, it's very much dependent on age of your patient. However, in your manual, it says 500 mils is probably about a ballpark figure for IV fluids. They need broad spectrum antibiotics, but the culture should be done before the antibiotics. Those broad spectrum antibiotics are relative to what your protocol is in your clinical setting. And then we would want to get a gas. Now, I appreciate that not every clinical area has access to a blood gas analyzer. But what you'd be looking for is the lactate. Is the lactate greater than 2 with appropriate fluid resuscitation? That would be another indicator for sepsis. And then urinary catheterization of your patient, because we want to keep an eye on the fluid balance of them. I think there's more questions come up there, Steve.
Yeah, Johnny. So we're just going back to the bleeding, rectal bleeding. There's specific packs for rectal bleeding.
Specific packs, did you say?
Yeah.
So I've never come across putting one in. But if you have PR bleeding, whether that's fresh blood or old blood, then the patient would need to have a scope, I would suggest, and be seen by gastro. If that is something that's available in your setting, it's about trying to manage the bleed, but getting IV access, putting oxygen on your patient. Any patient that is bleeding needs oxygen, and also fluids, but blood if and when you can get it. Also activating your massive hemorrhage protocol if you have that in your clinical setting. And I do appreciate that not every clinical setting has that. If you don't, then again it is 999. And stipulate that the patient is having a massive hemorrhage, and some emergency services do carry blood as well now.
And then just a question on if you suspect the post-op bleeding is from a cholecystectomy, is direct pressure suggested? So I think if it's internal bleeding, we would like the surgeons there as quick as possible.
Yeah,
and if it's an open wound bleeding, direct pressure would be good. And then just a question about a clarification: is it safe to administer tranexamic acid? Is there a suspicion of intra-abdominal bleeding post-operatively?
No, that's one thing that's being discussed heavily at the moment, is that internal bleeding, TXA, then there are schools of thought that say that it shouldn't be given. we use it for external bleeding.
Yeah, so just to make that distinction for external bleeding TXA, if it's internal, get the surgeons
Yeah,
involved.
absolutely. Because what you want to do is, so in terms of external bleeding, TXA works by it doesn't form a clot, it stops the clot breaking down. But in terms of internal bleeding, you want a surgeon because you want to turn the tap off to keep
Yeah,
it simple.
and then just before we move to asthma, just one thing on sepsis. Remember, it is sepsis until we decide otherwise. So all our patients will have sepsis. If you have got anything that shows that it's not sepsis, you can make a different diagnosis, but put that first and forward in your differential diagnosis. Johnny, is a last one on massive hemorrhage before we continue. By activating massive hemorrhage protocol, does it mean blood is also being arranged? Or
Yes.
need we to mention separately that you will transfuse?
No. So once you activate the massive hemorrhage protocol, then obviously the blood blank stops doing, well, the lab stop doing any other work and concentrate on that. In terms of scenarios, because it's a given in real life, but in terms of scenarios, what I would suggest, the response would be if your IV fluids have finished, because all you're doing is diluting the patient. If your IV fluids are finished, ask, is that blood available now? In terms of simulation. Does that answer the?
Yep, I think definitely. And then just last question, during my resuscitation of a patient with rectal bleeding, I was told I was supposed to pack the anus. So certainly if it's maybe after a hemorrhoidectomy or where we can pack it, absolutely good. But otherwise, if it's scenario, just get the surgeons involved as soon as possible. And in a real case, I suggest you do exactly the same. Right, Johnny, if we go to asthma.
Yeah, so in terms of asthma, then obviously treatment wise, so you want 5 milligrams of nebulized salbutamol. You want oxygen on your patient straight away. You want to do a thorough A to E assessment. Now, in terms of ipratropium bromide, then that's 500 mics for ipratropium bromide. In some clinical settings, that can be mixed with the salbutamol. In other clinical settings, they say that it can't because it's two separate drugs. And it's very much the same thing, is knowing what your clinical setting in terms of pharmacy approves or doesn't approve. So oxygen and your nebulizers. Also we can consider magnesium once you've got access with your patient. That'd be 2 grams of magnesium is recommended for these patients. But the big thing with if you can get a gas with asthmatics, that would be very appropriate. Certainly in our clinical setting, it would be an arterial gas, because you want to know what their CO2 is doing. Because if their CO2 is, and they're breathing fast, is raised or normal, it means the patient's getting tired. When they get tired, they're more likely to go into respiratory arrest. So you want anesthetic support straight away. As soon as you think that it's asthma, after anesthetic support in your simulations. So that's asthma. Is that more questions coming?
In a patient with known asthma, what SpO2 would you expect?
So if they're known asthmatic, then realistically, they should be no less than 90%. Really. So if you're thinking along the lines of COPD, it's 88 to 92% is acceptable for known COPD. But with asthma, you want to give them oxygen straight away.
Yeah, and I
without
think
questioning it.
with asthma, we want to get the oxygen concentration as high as possible. The CO2 may be normal if we can, but
Yeah,
in COPD, we need to be very careful with both of those as well, isn't it? And get
yeah,
the oxygen not too high, otherwise it will stop the driving of the breathing.
yeah. But then another question on the flip side of that is what's going to kill you first, hypoxia or hypercarbia,
Yeah.
really? So, but certainly just put oxygen on 15 liters via a non-rebreathe mask in any patient that is acutely unwell. Um, so opiate overdose. So there has been a couple of these scenarios, not so many, but a couple in terms of how we would treat it. Then that would be naloxone for the patient IV. So in terms of naloxone, remember that the action duration for naloxone is 45 to 70 minutes, whereas respiratory depression from opiate overdose may be 4 to 5 hours. So it may be that the patient needs more than one dose, but that's very much highlighted by, and I can't emphasize this enough, by doing your ABCDE assessment. When you've carried out a treatment, once that treatment has been delivered, it's reassessing at an appropriate time. And that should indicate whether your patient is deteriorating further or whether your treatment is having an effect. In terms of choking, then with choking, it's no different to your BLS or your PBLS guidelines, depending on what age category of patient you have, and that is doing your reassurance for your patient. That's massively important, but doing your 5 back blows and then your abdominal thrusts, 5 of those, and until the point that you would go into your normal BLS if the patient deteriorated and went into a rest. The local anesthetic toxicity, we've seen a few of these. There are a couple of malignant hypothermia scenarios that went about, but I think they'll get less after a discussion Stephen had.
Yeah, although we've said to hospitals that if they are bringing in scenarios, specifically in the recovery room after anesthetics, the anaesthetist should be involved immediately. And these malignant hypothermias is scenarios that we would like the anaesthetist to be the team leader, because this is not for every resident doctor out there. So hopefully we won't see many of these, but we would like you nevertheless to be aware of this malignant hypothermia. So maybe a good read for a bit of homework there.
Yeah, and absolutely, and request an anaesthetist or intensivist. So in terms of how we treat local anesthetic toxicity for your clinical settings that are providing, that sort of treatment, then you would use intralipids. So that's 1.5 milligrams per kilogram. And then it may be that they have a infusion dose which is more, but again, the safe thing to do is to look it up.
Indeed. So, Johnny, just back to naloxone. What is the minimum time interval between the repeat dosages of naloxone? And that's probably got to do with the half-life, isn't it?
Yeah, absolutely. Yeah. So if you think it's 45 to 70 minutes, it's about administering the dose, but then assessing your patient. And
Yeah.
if there is an effect, then great. If there isn't an effect, is it an opiate overdose?
Yeah, so really interesting questions.
Yeah,
Just
yeah.
one
It's
more
just
back
about
on,
assessment.
yeah, one more back on massive hemorrhage scenario. The surgeon was not available. Blood is being delayed. 3 liters of fluids gone in already. Is it the right decision to use colloids in the meantime whilst waiting for the bloods and 999?
Mm. That 3 liters of fluid's gone through before, and the surgeon's not available, and there's no bloods. That's a hard scenario.
Yeah, because the
And
more you pump in, the
hopefully
more it's
that
going to
wouldn't
run out,
happen.
isn't it?
Yeah. Yeah, that's harsh. Um,
Yeah, so certainly if you
colloids aren't the best thing, are they?
yeah, certainly
Really?
if you've given 3 liters of normal fluids, maybe a colloid, would do.
Yeah.
But I
Probably
can't see that
Hartman's
it's
would be
going to stop
better.
the bleeding.
Yeah, Hartman's would probably be better, to be honest.
Yeah. And then is there any important difference between RC UK and the ERC guidance regarding cardiac arrest?
That's a very good question. So, with the new guidelines that come out for 2025, then the very much a lot of the RCUK guidelines are taken straight from ERC,
Yeah,
because
so
they work very closely together.
it should be very much the same people writing the guidance for both, and they're on the same committees. And Johnny, then I've got a question. Can you just very briefly go over the local anesthetic toxicity treatment again, please?
Yeah, yeah. So it's so it would be 1.5 mils per kilogram of 20% intralipid, and then your infusion dose would be 15 mil per kilogram over an hour. However, you know, you want to be asking for expert help.
But certainly we will advise a bit of,
Intralipids usually kept on the emergency trolley if it's in an area that would potentially have that type of patient.
yeah, get anesthetics involved, and maybe a bit of reading on this one would be
Yeah, yeah.
absolutely fantastic.
Yeah, we one of my trusts that I was at, and then we certainly kept it on one of our trolleys, because of the type of patients that were being seen there. However, it's not a common thing, but it's not an unheard of you know reaction. Whereas your malignant hypothermia is, I've seen it once in my anaesthetic sort of rotation stuff, and that's in what 30 years now. Just show my age.
Yeah. Right, shall we move on?
Yeah, absolutely. So, in terms of pediatric scenarios, the same sort of thing. The only ones that are slightly different. So the tonsillectomy bleed, anesthetics for those of you that are in working in clinical settings that do tonsillectomies for pediatrics, then very much you will have anesthetics on site, and a surgeon as well. Those people should be contacted straight away, and obviously we treat it very carefully because it's an airway problem, but also it can be a C problem as well. So in terms of that, you would want to manage it, think about the patient, reassurance as well, but getting that expert help. Hypoglycemia, then very much read through your manual in terms of pediatrics for hypoglycemia and what the cutoff is in terms of minimals for that. It's 2 mils per kilogram of glucose 10%, if we're considering that. But very much the safe thing to do is to get the guidelines, and that should be available if there's a pediatric resuscitation trolley.
Yeah, I think really important in pediatrics, we are moving away from the mathematic perfection on wet flag to be able to use the algorithm and the charts specifically with these scenarios in pediatrics. So again, don't be afraid to ask for the for this sheets, but maybe more than that, long before the scenario, go and get them ready on the trolley. It's no use you ask for it, and it's not there. So make that part of your plan for the scenarios to have these scenarios ready for you.
Absolutely. And with pediatrics, if you're in a center that even if you're in a clinical setting that doesn't have pediatrics as patients, then you still will get pediatric scenarios because it's part of their risk stratification, like I said earlier, but for any visitors to that site. So if there's a pediatric visitor, then you need to be able to deal with an emergency. And it very much does throw up the question of what kit is available in terms of equipment for pediatric specific. A lot of places now are going towards pediatric grab bags rather than trying to route through an adult resus trolley for pediatric stuff. But
Yeah, and remember
remember,
that part of your role as the resident doctor is also to be the first aider on duty in the hospital. If there's a pediatric patient, maybe in the car park, or there could be a street in front of the hospital, then that is going to be part of your duty as well. So really important to keep your pediatric knowledge up to date. Don't be surprised if you see one or two pediatric scenarios in your hospital. And if you need some retraining, we would welcome you back. But a bit of reading of that pediatric scenarios would be absolutely fantastic.
yeah. And if you have scenarios and you've got questions or you want to discuss them, then do feel free to sort of to give me a call or an email. It's definitely worthwhile because my role is to support everyone going forward. So if we move on to the common themes, then in terms of the common themes that we're seeing on the reports written, the resident doctor does not identify themselves as the team leader or is hesitant in doing so. When you turn up, like I said earlier, introduce yourself and ask the first responder for a handover. So that way you're taking charge, you hear what the handover is, and then you can allocate your team from that. Also 360-degree access to the patient not carried out. Now, some of these scenarios are carried out, and like in emergencies in general, especially pre-hospitally, patients do not collapse in a nice, comfortable environment. They tend to collapse behind a door, in a bathroom, in a toilet. So if the scenario is being held within that sort of environment, think about compartmentalizing, where you bring the patient out to the next safe area that may give you access to your patient, because you want to be able to get round the whole of your patient to assess them and to work if it turns into a cardiac arrest.
And sometimes just moving the bed so that you can get to the airway would
Yeah,
be good as well.
taking the bed head off as well, moving it from the wall. Absolutely. Um, the A to E assessment lacks structure. So if you look at page 33 to 38, but that's in the new manual, or just think about your notes that you've maybe taken if you've done your courses recently. Just think about your A to E assessment, because I could say probably 95% of the reports that I see say the A2E assessment lacks structure. It doesn't tell me where. It will highlight some areas, but that is quite a blanket statement to me. So by doing a thorough, comprehensive A2E assessment, you will negate that happening. Analgesia not titrated to patient response. Again, remember what I said from earlier is that that if we're giving analgesia, we need to have a pain score for our patients so that we know what we're titrating the drug to. Confirmation of cardiac arrest not as per RCUK guidelines. This is very frequent. This comes out on reports. Remember, now it's not always you as the resident doctor, because you're the team leader, that actually confirms the cardiac arrest. It may be one of your colleagues, but I can't see that on the report. If you're worried about, the competence of them confirming cardiac arrest, do it yourself. The safest thing to do as the team leader, you take responsibility, look inside the mouth to make sure there's no problem in the airway, head tilt, chin lift, feel for a pulse whilst looking for rise and fall of the chest. And that's as per your RCUK guidelines, but that does come out quite frequently. Early requests for support. So as soon as you know you've got a sick patient, think, what help do I need? Now, whether that is you need to phone 999 because your clinical setting won't support higher levels of care. If you do that, phone 999 quite early. Remember, if the patient does go into cardiac arrest, to update the emergency services, which will change the response category of the patient. Pad placement not as per RCUK guidelines. So in terms of pad placement, so the left lateral pad needs now to be right up into the axilla, so right up into the armpit, because what we're trying to do is bracket the heart so that all the energy goes to where it needs to when you're defibrillating your patient. And that has started coming up quite a lot recently. But that's that pad placement was in the new guideline change, so that's why it's probably getting picked up.
And then for pediatrics, is it anterior, posterior?
Yeah, so if your patient is less than 8 years old, 25 kilograms, then we will do AP as the pad placement. But remember your safety as well, in terms of rolling the patient. Because if you're carrying out chest compressions and then getting the defib pads on, then any interruption in chest compression should be less than 5 seconds. But if we can make this a planned event, then it just reduces that time off the chest.
Johnny, just a question going with that. During the A2E assessment, does the leader's responsibility include making sure all members of the team are performing their part of the role correctly? For instance, proper placement of the airway or pad placement?
Absolutely. You as the team leader should have oversight. It's a stressful role, but it's stressful in real life. So
yeah, I think the assumption is that the team leader will be able to do everything. Will put the cannula, will be able to know the airway placement or the i-gel placement, pad placement. So you as a team leader have got that overall responsibility to make sure that your team is doing it correctly.
Absolutely. But in terms of, don't be afraid to, because this is part of the communication part as well, closing the loop of communication, can you insert an i-gel? Are you competent to do so? You may know that they're competent because they've already been allocated airway. When you insert the i-gel, because that's as far as we go in terms of ALS, then you want waveform capnography, and you want them to confirm that the airway is in place as well. by a planned pause off the chest to listen for air entry and also look for rise and fall of the chest, but that needs to be planned. So they'll do that, but you need to ask them to tell you when that has been done. In terms of pad placement, if you see, because you should be in an area where you can see the whole of the event, i.e. the bottom of the bed, that's not always possible depending on where the patient collapses, but you should be able to see that the pads are in the correct position. Does that answer the?
Yeah, perfect.
Yeah.
Emergency drugs?
Yeah, emergency drugs, not as per guideline. So, adrenaline. So, the simplest way to think about adrenaline, once you start using it, it's every other cycle from then. So, in terms of if your patient is in PEA, then continue chest compressions and give adrenaline straight away. If your patient is in a shockable rhythm, first of all, then it's after the third shock. But also we would use amiodarone. But what I think a lot of people get confused about is, say your patient is in PEA and then they have two shockable rhythms following that. It would be on the second shockable rhythm that you would repeat the adrenaline. You'd do it straight away, then you'd do it after every other cycle because you've already started it. Once it's been started, it's every other cycle. In terms of the amiodarone, that's given after the third shock and fifth shock. Okay, so after the fifth shock, that would be a half dose as well. But that all those things are on your guideline, so your algorithm. So if we no, maybe not. It's not. There we go. So on your algorithm, what to do when is on there. So don't be afraid to ask for the algorithm during your scenario because it is the right thing to do. Because in real life, it's also used because it is the right, safe thing to do. So don't be afraid to do that. And even to the point on here where it says immediately after ROSC, and this is something that we see come up quite a lot as well, is that there's not an A2E assessment post ROSC. So it even tells you what to do on that.
Yeah, and ask for these for these sheets because even the reversible causes, this is it's not a memory test, the scenario. So why not have it available on your trolleys, have it ready for use, and then you can actually properly go through the reversible causes instead of trying to remember all of them.
Yeah, absolutely. Yeah. In terms of, it's very well me saying, sitting here and saying this is what you should do, and I do appreciate that some scenarios are more difficult than others. But if you keep things simple, then and ask for algorithms, ask for looking up drug doses, obviously not your emergency drugs, because that should be a given that you know what dose to give and when to give it, which we've just talked through there.
Yeah, and then just a question, you've assessed A, B, and C, and then you're trying to interact with the facilitator of the scenario when a colleague cuts in and interrupts this whole process and destabilizing your thoughts. Any ideas?
Yeah, I've dealt with in emergencies. I've dealt with some strong characters. Um, so you can be direct without being rude. I think would be the way to go ahead. Your team should know that you're in charge by talking out loud. You're highlighting to the whole team what your thought process is. But just asking someone to hold on a second. What we're doing is you know, we're going through the reversible causes. And then at an appropriate time, you can ask for their input because that's good teamwork. But their interaction shouldn't disrupt your treatment of the patient. So just being polite and saying, could you just hold on for a second? What I'm thinking of at the moment is sort of thing. Does that answer your question?
Yeah, sometimes just give them some work to do.
Yeah, absolutely. If they've got time to talk, they're obviously not busy.
Absolutely.
Yeah. Right. So if we go back to this, so not all reversible causes were considered. So what we don't want is you to just list. You know, lists are an old thing. What we want to do is we want to be treating the most likely reversible cause, but not forgetting about the other reversible causes. If you can't remember them, ask your team, look at your algorithm. They're written on your algorithm. That will help you. But what you should be doing is treating the most relevant or most likely reversible cause. Every patient in cardiac arrest is hypoxic by default. So that is a given that you would insert an eye gel or ask your team to, and ask them to let you know when that's been done and check that it's working with waveform capnography. Two-person bag mask ventilation not carried out. So even if this is your day job, the research suggests that by doing this, you create a better seal. So if you're carrying out, or not you personally, if your team are carrying out chest compressions and there's one person on the mask, the person doing the chest compressions should squeeze the bag. That frees, you know, it doesn't take more than two people then, because you've got someone doing chest compressions as well as ventilating by squeezing the bag. All you need is that person on the airway to hold the mask in place. We see that quite a lot. Also extending, making sure that the equipment is fit for purpose. So when it comes in the packaging, if it's not been opened, then the bag is actually compressed. And a couple of times there has been in reports that this was not extended adequately. It's not so much now, but I have seen it a couple of times. And like I said, the advanced airway is not confirmed. So, you know, by closing that loop of communication, you're putting the onus onto your team that is managing the airway. Then, if it comes up, and I have seen this, and it came out in one report that I was reading, and it said that the airway was not confirmed. The advanced airway was not confirmed, although the resident doctor or team leader, it said team leader requested it. So that is very much the person on the airway needs a little bit of reflection or in your debrief that needs to be highlighted, that you've asked for the airway to be confirmed, and that wasn't carried out. No pulse check requested when a AED stated no shock advised. The AED knows whether it's a shockable or non-shockable rhythm. It doesn't know if the patient has a pulse or not. So the only way to check that, if it says no pulse, no shock advised, get my words out, then you need to ask your team to do a pulse check. And it should be the people that are up on the airway. You know, that's the quickest way to do it. And then confirmation of ROSC should be exactly the same as confirmation of cardiac arrest. Looking inside the mouth, head tilt, chin lift, feeling for a pulse, looking down the chest horizon fall. That, along with no shock advised on the AED, or if it's a manual, defib, then you analysing the rhythm to say it's a rhythm compatible with the cardiac output, and you have a pulse, confirms ROSC. Post-ROSC A2E assessment was unstructured. This should mimic exactly what you did when you were assessing your deteriorating patient. It should be no different. The added things that you would probably want on that, though, are things like, if they're available, you'd want 12-lead ECG or an echo. You would want a chest X-ray, and you would want some post-resus bloods. But every other thing should be exactly the same. And then the handover to emergency services was unstructured. So by using your SBAR-D handover, that will show structure, and that's what's recommended by the RCUK as well.
Yeah, and then do remember that if you do need to call the anaesthetist, always call the surgeon as well. Just inform them as well, because this patient should have two people looking after them or knowing about them, the surgeon and the anaesthetist on call. Johnny, just a question to clarify. I didn't really get what you said about looking through the algorithm sheets, because you also said that we expected to know the emergency medicines and know that by heart. How do you reconcile these?
So in terms of your algorithm tells you what pathway you should follow. Your emergency drugs as an ALS provider should be given that you know it. We're all human. If you need to look on the algorithm, but realistically, I would expect if I was in a team and there was a team leader, I definitely expect them to know what the emergency drug dose was.
And there's not many of them. There's adrenaline and amiodarone.
Yeah, it's not. Even I can do it. So
yeah, so the salbutamol and all the others you can look up, but those
yeah,
two,
absolutely.
you
Just
should
those two.
know by heart.
Yeah, yeah. But if you do get stuck because it's a kinetic or very busy, frantic environment, then the safe thing to do to take that burden away is to get the algorithm.
And maybe in pediatrics, use the algorithm, but you
Yes,
should know
absolutely.
how to complete wet flag as well. So have a look at those dosages, specifically fluid, the glucose, lorazepam, and the adrenaline. Those are the important ones. And the defibrillation dose, of course.
Yeah, yeah. So we just quickly looked at this before. So, don't be afraid to do it. I would expect you to know the dose of the emergency drugs, but don't be afraid to get this out if you need to, or ask one of your colleagues to look it up as your team lead in the event. This is the PALS one. So in terms of this, obviously no different, just drug doses and energy doses for your patient would be different. But if you don't see pediatrics very often and you have a pediatric scenario, your go-to would be this straight away, just to make it easier for you. Okay. And you would want expert help as well, and do that early. So if you have any issues or questions regarding resus, patient deterioration, or simulation, you can contact me. So in terms of, I will see all the reports that come through. I may phone you up to have a discussion with you. This is not about me blaming anyone. This is about me understanding more about the report, because it's not always evident of who's initiated what, if that makes sense. But also it may be that I have a learning conversation with you, and this is about support and learning going forward. everyone needs learn every day. I like to learn one new thing at least every couple of days. It doesn't have to be medical, but it just keeps me interested. So having a chat with me is not the end of the world.
Yeah,
Um,
thank you, Johnny. You're doing an amazing work for our doctors at NAS in support and training. So I wonder on that note, if I can ask you to use the react button and we just say thank you very much for Johnny giving us his time. We are more than 100 on the webinar today. We are running out of time. So, Johnny, on behalf of us, thank you so much for spending your time with us. And I can see the screen is full of appreciation for you.
yeah,
We will put this on our Moodle platform where you can look or listen to this again. And for CPD, I would be very happy as your responsible officer if you put 1.5 hours down for CPD, 1.5 points, and you can self-declare that you have been part or taking part in the webinar. So very, very happy for you to add that to your CPD and to your appraisals, because you also need to show that as the resuscitation team leader, you've kept your skills up to date. So, Johnny, thank you very, very much.
thank you.
Much appreciated your time. And then we'll stop the recording and happy for all of you to continue your hard work in hospitals and make success of your simulation training.